you for listening. My name is Ritika, and I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today, we'll be talking about a case I dealt with recently involving a hemorrhagic stroke, the deterioration I witnessed, and the importance of fast management. As a disclaimer, I will not be providing any personalized information, and all names, numbers, and results will be altered to protect the privacy of the patient this story is derived from. Before we get into the nitty-gritty, let me provide some context for the situation. What is a stroke? Strokes occur as a result of insufficient blood flow to the brain, causing cell death and therefore certain neurological deficits. It is potentially a fatal event. It kills more women than breast cancer and more men than prostate cancer. It is such a common event too. In 2023, an estimated 45,785 stroke events occurred in Australia. That equates to one stroke every 11 minutes, which is insane to think about. If you think it won't happen to you though, 1 in 4 strokes occurred in people under 65. Strokes can occur 2 ways: ischemia or hemorrhage. Ischemia, in fancy words, is a lack of blood flow. Ischemia happens to you all the time. Just think of a stitch when running on a full stomach. The pain is a result of a lack of oxygen to the vital organs, causing pain, getting you to stop, and therefore increase oxygen uptake through bigger breaths. Same thing happens in the brain. A clot or plaque from high cholesterol dislodges and makes its way to the vessels in the brain and causes a blockage. Everything beyond the site of the blockage, though, is now not being perfused, which means supplied with blood. The extent of the damage is relative to where the blockage is and how much of the brain is affected. Hemorrhage is pretty self-explanatory. Just like if you were to get stabbed or shot, suddenly start gushing blood, the same thing happens in the brain. Increased bleeding puts pressure on the brain and subsequently starts causing brain cell death. This is important because there's only so much space in your skull. If the brain starts bleeding, then there will be an eventual limit to how much the skull can hold, on top of the brain itself and cerebrospinal fluid. Hemorrhages can be caused by a number of ailments. Aneurysms, which are spots of weakened arterial walls, which can rupture and cause bleeding, but we'll deep dive into the pathophysiology of aneurysms another day. And falls in the elderly are another large contributor to hemorrhagic strokes. Being on blood thinners and falling onto your head often is a surefire way to start bleeding. The most common type of stroke is an ischemic stroke, but that does not discount the importance and severity of a hemorrhagic stroke. When a stroke starts, it attacks up to 1.9 million brain cells a minute. The lack of time-efficient treatment increases mortality without a doubt, whether that be a direct ineffectiveness of treatment or further down the line as a complication. Now that we've learnt the basics of strokes, and are a little freaked out by it too, let's learn about the patient. We'll call him Stephen for today. Stephen presented to the emergency department with 2 days of stroke symptoms as reported by his wife. 2 days ago, he had taken a tumble and hit his head, and as per the wife, he immediately started displaying stroke symptoms, like increased confusion, slurred speech. When imploring her husband to be seen, he allegedly had brushed it off and said he didn't want her to call an ambulance. And the next day, there was minimal contact between the husband and his wife due to a headache, which is another telltale symptom of a stroke. And on the 3rd day, they finally came in without an ambulance. This will become important later. Stephen ended up waiting over 2 hours for a CT scan of his head. This was due to departmental pressures, high acuity, and a large number of presentations. It is pertinent information to know that he had a history of atrial fibrillation and therefore was on a blood thinner. We will discuss atrial fibrillation and the need for blood thinners another day. We see so many potential strokes in the department, which thankfully turn out not to be strokes, but unfortunately there are a few. For those few to receive time-efficient treatment, it is important to assign a high category for all presenting with stroke symptoms, no matter how unlikely it is that they will have a stroke or not. This man had not been seen in the advised 10 minutes that having an Australian triage scale category 2 would expect. He was not seen until after his CT. 2 hours into waiting in the waiting room, his wife had asked to more for his headache. All potential stroke patients must remain nil by mouth, which is nothing to eat or drink, until it is established by a credentialed nursing staff through an assist assessment, or, if they fail an assist, through speech pathology that the patient can swallow without the risk of aspiration, inhaling food or drink instead of swallowing it. My colleague is credentialed and can perform an assist. She pulled him through to find him utterly confused, unable to walk properly, and quite agitated in his confusion. This is when I meet Stephen for the first time. He is brought into my cubicle and we go straight to CT together. This is where I begin to grasp the seriousness of the situation. He's so confused that he physically cannot sit still in the scanner, and as a result, we were only able to get half of the scans we required. Luckily, it was a scan of his brain. On my cursory and definitely not professional look, even I could clearly see that there were multiple abnormal looking spots on his scan. For those that can comprehend jargon, he had multiple hematomas, a subarachnoid hemorrhage, and a subdural hemorrhage. We got back to the cubicle and I made my findings and concerns known to the nurse in charge and the senior doctor of the doctor that had assigned themselves to the case. In this time, Stephen had deteriorated immensely. He was ripping everything off him, wasn't able to be settled by his wife. At this time, I was told to give him medication to reverse the effect of the blood-thinning medications and to stop the bleed from getting worse. To be frank, I have not done this before, so I equipped a CCRN to help me, who had also not done this before. Together we figured it out. We got back to him with the medications just in time to witness him have a focal seizure, in which his face began twitching uncontrollably. This lasted about 40 seconds, and at the end, his facial droop and confusion had worsened like tenfold. At this point, we were discussing with the neurosurgery experts, and it had been arranged for him to be what we call lights and sirens out to the specialist center so they can assess and make the decision whether to operate or to palliate. Given Stephen only became my patient after 2 hours in the waiting room, he was scanned, assessed, treated, and sent to the specialist center in about an hour and a half. Upon reflection, my care for the patient was to my own standard. I essentially took him on one-on-one in a low acuity cubicle, where ideally he'd be one-on-one in resus. Luckily, we were in double staffing time, and the other nurse was there to care for my other 2 patients. To be completely honest, I had never seen deterioration occur that fast, and I mean within a matter of minutes. It was a very scary time, far away from the senior nurses and the doctors that could provide me with assistance if I needed it, which I did. Having such supportive team members, though, is what allowed me to confidently care for this man and escalate his deterioration. Reflecting critically on the situation, he should have had his CT more urgently, knowing the backstory to his symptoms despite him appearing cognizant and able to walk when he first came in. If stroke protocols had been followed, the bleed would have been discovered 2 hours earlier, providing for earlier treatment and earlier transfer. Stephen may have permanent deficits as a direct result of this delay. This possibility weighs down my conscience every day and keeps it in the forefront of my mind. That way, when I'm ready, or next time, I'm ready on my A game to get the patients assessed and the care they need faster than the last. We have a dedicated stroke nurse consultant who I know personally, and she is a wealth of knowledge and expertise, as well as a very easy person to call, approach, or discuss concerns with. Whenever we have a possible stroke or any stroke concerns, she implores that we call her and she'll come on site. I found out after Stephen had left that our stroke CNC was not called at any point during Stephen's stay with us, even after I had asked when he first came to me. Not calling the stroke CNC early is probably what allowed this man's CT to be pushed to 2 hours after arriving to ED. Understanding strokes and the consequences more than any of us, she would have had the pull to be able to get CT to make him a priority over everyone else in the queue. But this did not happen. What I have learnt from this is that I can call her if I think no one has, even if She has been called and it just was not documented. If I am unsure, the best place to get advice is an expert in the field, not to just wing it and hope for the best, which is what I ended up doing. If you have gotten this far, thank you for listening to me explain my own vulnerabilities and allowing me to reflect and come up with ways to make myself a better nurse. Now I will use the knowledge to help you, if you ever need it. You may have heard of the acronym FAST. This stands for face, arms, speech, and tongue. The most common stroke symptoms, regardless of type, are a one-sided facial droop. This can be tested by getting the person to smile, and if one side won't lift, well, they've got a facial droop. Weakness or altered sensation in one arm and or leg is usually the same side as the facial droop. Which side the weakness is on, and as well as the facial droop, will likely indicate that the stroke is on the other side of the brain. For example, right-sided weakness indicates a left-sided stroke. Speech may be affected too. They may stop making sense, start speaking gibberish, or have slurred speech. And time is to remind you that if anyone is displaying these symptoms, that they need to be rushed to the hospital to be assessed. The time to treatment is a direct factor in the survivability and likelihood of long-lasting deficits. Now, the importance of calling an ambulance cannot be understated. 1. They can rush through potential traffic faster than you. 2. They are skilled in determining whether these symptoms are present. 3. There is a mobile stroke unit within Ambulance Victoria that can be dispatched and take you to the nearest specialist clinic while having experts on board beginning treatment before you even reach the hospital. And 4. Even normal crews can begin treatment before hitting the hospital. These are all things you as an ordinary person in an ordinary car cannot do, and you may endanger the person as a result. So always call an ambulance. Tell them you think this person is having a stroke and tell them why you think that is so to help them get a crew to you faster. If someone is suspected of having a stroke, never feed them. Not water, not food, nothing. If their swallowing capability is affected, they could inhale the food or water, leading to aspiration pneumonia, which can be fatal. So even if it is unlikely, like being drug affected or in a really, really deep sleep, do not give anything by mouth. So what we've learned today is what a stroke is, the different types of stroke, and the case of Stephen. An unfortunate case where he was not attended to in the time the ATS triage category 2 expects, and a result deteriorated right in front of my eyes. We now know the symptoms that we should be looking out for and what to do and what not to do in case this happens to us. This wraps up my first episode of my show, Chronicles of a Learner RN. I certainly have learned a lot, and I hope you have too. Whether you have gained the confidence to escalate or learned the importance of time management with strokes, or just learned how strokes work. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. I just wanted to as well reference the facts that I had at the start of the episode came from Stroke Foundation Australia. With many thanks. So thank you and see you next time.